Hello, Nursing 222. This lecture will discuss the cardiac arrhythmias or dysrhythmias. Here are your objectives for this week's content. And here are some added lecture objectives for this week's content. Okay, so yes, the cardiac conduction system. So here's another quick review before we talk about the dysrhythmias. The SA node starts the sequence by causing both the atrial muscle to contract. This is atrial depolarization, and this is what causes the P wave on the EKG. Then there's a slight pause, which is the PR interval. The blood moves through the AV valves to allow the ventricles to fill. Then the impulse moves to the AV node, down through the bundle of His, down the left and right bundle branches, and terminated in the Purkinje's fiber, causing the ventricles to contract, and this is ventricular depolarization. All of this is represented by the QRS complex. Then there is another pause, which is the ST interval, then the T wave, which represents the ventricular repolarization so that the heart can regain the negative charge and start this whole electrical impulse all over again. So again, let's do a quick review or overview. The SA node starts the sequence by causing both the atrial muscles to contract. This is atrial depolarization, and this is what causes the P wave that you see on the EKG. Then there's a slight pause, which is the PR interval. The blood moves through the AV valves to allow the ventricles to fill. Then the impulse moves to the AV node, down through the bundle of His, down the left and right bundle branches, and terminating in the Purkinje fibers, causing the ventricles to contract, and this is ventricular depolarization. All of this is represented by the QRS complex. Then there's another pause, which is the ST interval. Then the T wave, which represents ventricular repolarization, so the heart can regain the negative charge again and start this whole process all over. And what happens with the arrhythmias or dysrhythmias is that there's an interruption in this cardiac conduction system, and it throws the patient heart rate off. Either the heart rate is too fast, it's too slow, or the rhythm is irregular. So arrhythmias may be broken down into general categories. You have your varying rhythms, where maybe the rhythm is irregular, it's too fast, it's too slow. You have extra beats, you have skips in the rhythm, you have rapid rhythms, and you have heart blocks. This is helpful in recognizing the pathophysiology of the arrhythmia. So let's first start with the normal sinus rhythm. This is what we all should have and would like to have, and we want our patients to have. So the heart rate is between 60 and 100 beats per minute. That's the normal range for a heart rate. The rhythm has a regular pattern. There is a P wave before every QRS, and they are all identical. The QRS is 0.12 seconds. The PR interval is between 0.12 and 0.20 seconds when we measure it. So this is the normal sinus rhythm that you want to see on the EKG to let us know that everything is working, the electrical activity of the heart is normal. So let's start with the sinus node arrhythmia, which is a varying irregular rhythm often due to coronary artery disease. In this arrhythmia, the pacemaking impulses, it will originate in the SA node like it's supposed to. All the P waves are identical. The QRS, T, and T waves of each cycle are usually normal and is similar in size and shape when you look at a strip. But the timing of the cycle is irregular. So when you listen to a patient heart rate and you don't hear any extra sounds, any abnormal sounds, it's just the rhythm is off. So we hear about bradycardia all the time. So let's talk about sinus bradycardia, which is a disruption in the normal electrical impulses causing a slow heart rate, less than 60 beats per minute. In some patients, you remember I said that in trained athletes, they may have a low heart rate, and that's fine for them. As long as the patient is asymptomatic and is perfusing the body well, then there is no need for concern. Many things can cause or contribute to sinus bradycardia, including any damage to the heart tissue, either related to aging, related to a heart attack or hypertension or a congenital heart defect, maybe an infection of the heart tissue or myocarditis, and we'll talk about that later. Complications of heart surgery. Sometimes an underactive thyroid gland, hypothyroidism, can cause sinus bradycardia, imbalance of electrolytes, sleep apnea, inflammatory diseases such as rheumatic fever or lupus. Sometimes if a patient has a buildup of iron in the organs, hemochromatosis, that can cause sinus bradycardia and infect the heart, and also certain medications. A patient with bradycardia may not get in. The patients who have symptoms or who are symptomatic, they may not get enough supply of oxygen that they need to the brain or other organs, and then it results in some symptoms. And so if the patient is symptomatic, they can have near fainting or syncope episodes, dizziness, weakness, fatigue, shortness of breath, chest pain. They can have confusion or memory loss, and also hypotension, because the heart is not pumping fast enough to perfuse the body. Treatment for bradycardia depends on the type of the electrical conduction problem, the severity of the patient's symptoms, and also the cause, the underlying cause of the bradycardia. The diagnostic test, of course, the EKG, and this will be common throughout all the arrhythmias. That's the primary tool for evaluating bradycardia. They may use a Holter monitor, which is a portable EKG device that is carried in the patient's pocket or worn on a belt or a shoulder strap, and it actually records the patient heart activity for an entire 24-hour period, which provides us with information regarding the patient heart rhythms in a 24-hour period. So the patient is required to keep a diary during the same 24-hour period. So when the patient has any symptoms, they need to describe their symptoms, the time, and record what they felt when they were having the symptoms, and then they will turn it into their physician. An event recorder is also a portable EKG device intended to monitor the patient activity over a few weeks or a few months. So the patient activates it only when the symptoms are experienced, and then they may, or all the symptoms that are experienced to a related bradycardia episode. So they will only push the button and record it whenever they have an episode or have symptoms. So when the patient feels these symptoms, they push the button and the event is recorded. This gives us information to help determine the patient's heart rhythm at any time during the symptoms. And then, of course, those recordings are turned over to the cardiologist. Treatment for bradycardia is really to treat the underlying disorder. So if a patient has an underlying disorder that's causing bradycardia, such as the hypothyroidism, then you need to treat that. If it's sleep apnea, then you treat the sleep apnea with the CPAP machine and medications if they need it. Treatment of the disorder may correct the bradycardia, and it may not, but they still have to treat the underlying cause. Changes in medication. So a number of medications such as meds to treat heart conditions can cause bradycardia. We need to assess our patient meds, and then we also need to and the provider may recommend alternative treatment if this is the source of their bradycardia. We need to change the drugs, or the physician will change the drugs or lower the dose, and that may in turn correct the bradycardia also. Atropine is a common drug we use to treat bradycardia. So if a patient has bradycardia, you may see that on their MAR. When alternative treatments aren't possible or not working, and the treatment is not working, then the patient may need a pacemaker to help pace the heart and to keep the heart pumping. There's internal pacemakers, and we'll talk about that also, but there's internal pacemakers and there's external pacemakers. So if they do have an external pacemaker, it is a temporary means of pacing the patient heart. Then the patient may need a permanent pacemaker, and that would be your internal. So a pacemaker is battery operated. It's a device implanted under the patient collarbone. There's wires from the device are threaded through the veins into the heart. Electrodes at the end of the wires are attached to the heart tissue. So the pacemaker monitors the patient heart rate and generates an electrical impulse to help control the patient heart rate. If the pacing is unavailable or ineffective, then we use medications such as dopamine or epinephrine infusion to help that. So pacemakers can be used for bradycardia and also fast heart rates as well, or rhythms. So on EKG, what would you see? The rate will be less than 60 beats per minute. The rhythm is regular because it is sinus, right? The P waves is consistent in size and shape, and the P wave is before each QRS, and the PR interval is normal, and the QRS duration is normal. So everything will be normal about it except the rate. It will be less than 60. So if you look at the strip here, and if you count the R waves, it is 4, 1, 2, 3, 4 times 10. If you remember the calculations from the last lecture. So that means your patient rate is 40. Or you can look at the dark red lines and use the method of the 300, 150, 175, 60, and 50. And then you can count it that way as well. But your rate, according to this strip, would be 40 beats per minute. So it's less than 60. Everything else is normal and regular. So that means that it's a sinus bradycardia. So tachycardia or sinus tachycardia occurs when there's an abnormality in the heart that produces a rapid electrical signal or rate. It is a seriously disruption in the normal heart function. It increases the patient risk of stroke, and it also increases the patient risk of sudden cardiac arrest or death because the rate is too fast. It still doesn't perfuse the body like it's supposed to. Many things can cause or contribute to tachycardia, such as damage to the heart tissue, again from heart disease, an abnormal electrical pathway in the heart present at birth, so it could be a congenital defect or disease, anemia, exercise. It can be exercise-induced, stress-induced, hypertension, smoking, drinking too much alcohol. If a patient is drinking too many caffeinated beverages, then that can also cause sinus tachycardia. It can also be a side effect to certain medications, abuse of recreational drugs such as cocaine, imbalance of electrolytes, or overreactive thyroid such as hyperthyroidism. So unlike the sinus bradycardia with the underactive thyroid as a cause, overactive thyroid or hypothyroidism is can be a cause for sinus tachycardia. In some cases, tachycardia can cause no symptoms or complications. However, when the heart rate is too fast or rapid, like I said, it does not effectively pump blood to the rest of the body, so it deprives the organs and tissues of oxygen, therefore causing signs and symptoms such as dizziness, shortness of breath, lightheadedness, heart palpitation, chest pain, syncope, some of the same same symptoms because it's not perfusing the body. Diagnostic tests will be the same as for bradycardia, the EKG, Holter monitor, and event monitor. Treatment for tachycardia may just correct itself, but it can slow the heart rate by using vagal maneuvers. Vagal maneuvers affect the vagus nerve, which helps regulate heartbeat. So the maneuvers include coughing, bearing down as if the patient was having a bowel movement, and putting an ice pack on the face. Or sometimes if they place both hands in a sink of ice water, that can stop the rapid heart rate. Medications, if vagal maneuvers do not correct the tachycardia, the patient may need injection of an antiarrhythmic medication to restore the normal heart rate. Antiarrhythmic drugs such as Tambo, so sinus tachycardia is the heart rate greater than 100 beats per minute. It is an abnormality in the heart that produces a rapid electrical signal or rate. This increased rate can increase the patient risk of stroke or sudden cardiac arrest or death. Some of the risk factors that predisposes a patient to tachycardia would be damage to the heart tissue from heart disease, some of your congenital heart defects or disease, anemia. It can be exercise or stress induced, hypertension, smoking, drinking too much alcohol, drinking too much caffeine, medication. It can be a side effect from certain medications. It can also be caused by abuse of recreational drugs such as cocaine. It can be caused by imbalance of electrolytes and an overreactive thyroid, such as your hyperthyroidism. In some cases, tachycardia may not present any symptoms or complication. However, when the heart rate is too fast, it's not going to effectively pump blood to the rest of the body. So it deprives the organs and the other tissues of oxygen. Therefore, it can cause some symptoms such as dizziness, shortness of breath, lightheadedness, heart palpitation, chest pains, syncope. So some of the same symptoms because the body is not being perfused well. Diagnostic test is the same for bradycardia, the EKG, Holter monitor, event monitor. Treatment, sometimes it corrects itself, and then sometimes we can do vagal maneuvers where it affects the vagus nerve and it helps to regulate the heartbeat. So things such as coughing or bearing down, like the patient is going to have a bowel movement, or placing your hands in a sink full of cold ice water or maybe an ice pack on the face can actually correct the rate. But if the vagal maneuvers do not correct the tachycardia, then the patient may need to be on some type of antiarrhythmic drug to help normalize the heart rate. Cardioversion may also be used. It is a procedure in which a shock is delivered to the heart through paddles or patches on the chest. So the current the current that is given to the patient affects the electrical impulses in the heart and it actually restores the patient rhythm back to normal. It's generally used when in emergency care and is needed when the maneuvers or the medications are ineffective. So if tachycardia is due to blood loss, then the patient will need some fluid replacement and a blood transfusion to help the tachycardia. So here's a strip on sinus tachycardia. So on an EKG, the rate is greater than 100 beats per minute. So the rhythm is regular again. The P wave is consistent in size and shape, and the P wave is before each QRS and they are identical. And the PR interval is normal, and also the QRS duration is normal. So again, everything is normal except the rate is greater than 100. So if you count the R waves in this strip, you have 12. And then you multiply 12 times 10, because there's a 10-second intervals, which will give the rate at 120. So there's 120 beats per minute, which makes it tachycardia, and it's sinus because everything else is normal. So let's move on to atrial arrhythmias. So it is an abnormality that occurs in the left or right atrium. There are three types that we will discuss: premature atrial complex or PAC, atrial flutter, and atrial fibrillation. So to explain the diagram, in the diagram, the impulse starts with the stimulation of the SA node in the right and left atrium. Then it stimulates the AV node and then sends an impulse to both ventricles. But, that's the normal when you look at the normal electrical pathway. But in atrial arrhythmias, the stimulation is coming more from one focus point within the atrium. So if you look at the picture on the right, you can see that there's multiple areas where the stimulation is coming from, not just the SA node where it's supposed to. So let's start with the premature atrial contractions, or PAC. These are very common. They are benign arrhythmias. A PAC is a heartbeat that originates away from the SA node, which sends electrical signals through the upper chamber of the heart, or the atrium. It usually occurs after the sinus node has initiated one heartbeat and before the next regular sinus discharge. So the patient may be asymptomatic, or they may feel like their heart has skipped a beat, and it can occur with the intake of caffeine, tobacco, alcohol, or stress can also bring on PACs or increase their frequency. So like I said, these are benign. When you do feel your heart beat skip, this is what you're probably having, is a PAC. So the heart rate depends on the underlying rhythm. So the rhythm is irregular because it is firing prematurely. So the P wave is abnormal or hidden because remember, the P wave is represented by the signal originating from the SA node. So in a PAC, it does not originate from the SA node. It can originate from anywhere within the atrium. So the size and shape of the P wave is different than what it is generated if it had come from the SA node. The PR interval is greater than 0.12 seconds, but shorter than the sinus generated PR interval. The QRS duration is normal, however. PACs are usually infrequent. It requires no treatment as long as the patient remains stable. However, if a patient is hospitalized and the patient is having at least 6 PACs per minute, then we are concerned that the patient condition is getting worse and may be developing an atrial fibrillation, in which we will discuss in the next few slides. So again, PACs are benign arrhythmias, and they can be brought on by something as simple as caffeine intake. So here is an example of a PAC diagram. You can see that the impulse is not coming from the SA node. So atrial flutter, which is a coordinated rapid beating of the atria. Most patients who experience atrial flutter are 60 years of age or older and have some type of underlying cardiac disorder, such as a heart valve problem or hypertrophy where the heart muscle is thickened. Because the rate is so fast, the AV node cannot conduct the impulses into the ventricles. So what happens is it increases the patient risk of stroke due to an emboli because the atrium doesn't contract properly. The blood actually pools in the atrium and the blood doesn't move down into the ventricles, and it can also cause the patient it increases the risk of clots, but it causes the patient to be at risk for atrial fibrillation, and we'll talk about that next. Causes of atrial flutter include a patient with coronary artery disease, hypertension, mitral valve disease, and hyperthyroidism. The patient with atrial flutter may not have any symptoms, but if they do, they may have hypotension because the heart is not going to pump well. It's not the blood is not moving down into the ventricles. They may have shortness of breath, fatigue, chest pain. So your similar cardiac issues. Treatment: if the patient is unstable, they may need cardioversion to help convert the rhythm. But if the patient is stable and the QRS is narrow and the R to R interval is regular, we will administer IV med adenosine rapidly over 1 to 2 seconds, and then we follow that by rapid IV infusion of a saline flush. If the adenosine fails to convert the rhythm or the R to R interval is irregular, then they will cardiovert using certain medications to help convert the patient as well. Is usually pushed rapidly IV to slow the conduction of the dysrhythmia. The patient vital signs should be monitored when we give this med or this treatment, and you should always assess the patient for signs and symptoms such as headache, facial flushing, because we're actually flushing pretty fast. shortness of breath, and nausea. The signs and symptoms are usually short-lived because the drug has a short duration. We should also monitor the patient for any cardiac signs and symptoms such as bradycardia, hypotension, sinus arrest as well. So we're assessing the patient closely. If the meds are ineffective, they may use electrical cardioversion. If the flutter lasts longer than 48 hours, then we may add anticoagulants prior to the cardioversion to try to prevent clots. When you look at the rhythm on the EKG strip, the heart rate is usually between 220 and 350, as your book states, but it can go a little over 400, and the ventricular rate is usually slower than 300. But the rhythm is usually regular, but it also can be irregular too due to the change in the AV conduction. The P waves are identical in pattern, but it has like a saw-like pattern because the impulses are coming throughout the atrium and not just from one focal point. The PR interval is not measurable, and the QRS is normal, and that's because when the impulses are going to the ventricle, it is normal. So the ones that actually go to the ventricles are normal. Only occasional atrial stimulus will stimulate the AV node. So there are a few flutter waves before the QRS complex. So that's what you're seeing, is that they're coming from they are stimulated from more than one focal point. So if you look at the diagram and you see that the impulses will go in a circular pattern, some of the impulses will go down into the ventricle and stimulate the ventricles, and that's why you do see some QRS complexes on the EKG. But when it doesn't, you see that saw-like pattern because it's not going down into the ventricles to get that QRS complex. Atrial fibrillation is an irregular rapid heart rate that commonly causes poor blood flow to the body. The two atrias beat very chaotically, out of coordination with the two ventricles. So the erratic contraction can cause the formation of a thrombus within the atrium, increasing the patient risk for stroke. Patients with AFib often have symptoms that include heart palpitation, shortness of breath, weakness, because the loss of atrial contraction causes a reduce in the ventricular filling volume, and therefore it reduces the patient cardiac output. Chest pain and angina angina can also be symptoms as well. Atrial fib is associated with advancing age, valve disorders, coronary artery disease, hypertension, diabetes, heart failure, lung disease. All these things can cause atrial fibrillation. Hyperthyroidism, if a patient had a recent heart surgery, drugs, and also caffeine. Episodes of AFib can come and go, or patients may develop AFib that doesn't go away and may require some type of treatment. It can lead to complications such as blood clots forming in the heart that may circulate to other organs and lead to block blood flow and cause ischemia and tissue death and organ issues. Treatment depends on how long the patient has had the AFib. It also depends on how the patient tolerate their symptoms. Are they able to live with their symptoms and the underlying cause of the AFib? The goal of treatment really is to reset the rhythm or control the rate, and also to prevent blood clots. They may perform electrocardioversion. Is indicated if the patient is unstable, hemodynamically unstable. However, cardioversion is contraindicated in patients who have had AFib longer than 48 hours due to the risk of atrial thrombus, unless they have received anticoagulants. So if they receive anticoagulants with the cardioversion, then okay. But if not, it's contraindicated. If the patient has had an acute episode within 48 hours, then we would administer adenosine IV. We would give warfarin or Coumadin. Is indicated if a patient has a high risk for stroke. The patient may be started on heparin until therapeutic levels of Coumadin can be achieved. If a patient is unresponsive to then the patient may need a pacemaker or catheter ablation, which uses radio frequent energy. Maybe cryotherapy to use extreme cold or extreme heat to destroy hot spots, what they call it, the ones that are triggering these rhythms or irregular rhythms. So what happens is with these hot spots, they discharge these triggers, which causes tissue scarring so that the erratic signals can actually start to normalize. So this corrects the arrhythmia without the need for medication or pacemakers. On EKG, what you will see for AFib is that the rhythm is irregular. The rate is very fast, usually greater than 350 beats per minute for atrial rhythm. But for the ventricular rate, it may be slow, normal, or it could be fast as well. But the atrial rhythm rate is greater than 350 beats per minute. The P wave is absent, or could be absent, but if it is present, it would be erratic waves that you will see. The PR interval may also be absent as well. The QRS is normal, but it can be widened if there are some delays in conduction. So that's what you will see on a EKG. So if you look at the strip for AFib, the P waves, if they are present, they may be replaced by these wavy lines. The atrial impulse is irregular, and the ventricle impulses are also irregular, causing shallow spikes that you see on the EKG strip. So here's another diagram of atrial fibrillation. If you look at the diagram, you can see that the atrial impulses are not traveling very far. It's firing rapidly throughout the atrias, and some of the impulses will go down into the ventricles, but may have a delayed response. And so that's why you see the wavy lines on the EKG strip. So let's move on to ventricular arrhythmias. Ventricular arrhythmia starts in the heart ventricles. So the ones we're going to discuss is premature ventricular complex, or PVCs, ventricular tachycardia, ventricular fibrillation or VFib, or ventricular asystole. So premature ventricular contractions, or PVCs, are extra abnormal heartbeats that begin in one or two of the ventricles. So these extra beats disrupt the regular heart rhythm, sometimes causing the patient to feel like a flip-flop or skip beat within the chest. Premature ventricular contractions, or PVCs, are very common. They occur in most people at some point. They're similar to PACs. The impulses originate in the myocardium, or the heart, which is outside of the conduction system, so the impulse is slower. With PVCs, it can be coupled with a normal beat, and it is repeated. So this is called bigeminy. So every other beat is a PVC. It can also be coupled with two normal beats, and the pattern will repeat itself many times, and this is called trigeminy. So every third beat you will have a PVC. They can also be coupled and triplets as well, meaning 2 or 3 in a row. If a healthy patient has occasional PVCs, there is no reason for concern and no treatment is needed. But if the patient has frequent PVCs or underlying heart disease, then the patient may need treatment to help them either feel better and not have any of these symptoms. And also we need to treat the underlying heart problem. The rate in PVCs depend on the underlying rhythm. The rhythm is usually regular. The P waves depend on the timing of the PVC. The P wave may be present or absent because it is hidden within the QRS, or the T wave. So if the P wave is after the the QRS wave, then the P wave would be different. The PR interval is less than 0.12 seconds, and if the P wave is present, The QRS wave is wide and abnormal in shape, and the duration is 0.12 seconds or greater. Premature ventricular contractions often cause no symptom, but if a patient does have symptoms, they may feel like an odd sensation in the chest. Like I said, it's like a flip-flop, fluttering, pounding, or jumping, or skip beats, or palpitations, they may describe it as. The reason they're really not clear what really causes the PVCs. However, there are certain triggers, like heart disease or a change in the body can make cells in the ventricle, or it can cause changes where the electrical system is unstable. Underlying heart disease or scarring may also cause changes in electrical impulses within the heart. PVCs may also be associated with chemical changes or imbalances in the body. Certain medications, including asthma medication, alcohol, or illegal drugs, increased caffeine, tobacco use, exercise, or anxiety can also cause PVCs. Injury to the heart muscle from coronary artery disease, congenital heart disease, hypertension, or heart failure, all of those things can also cause PVCs. So treatment, really, we can make lifestyle changes, eliminating some of the common PVC triggers such as caffeine or tobacco. So you have to identify when the patient is experiencing symptoms. Is it after the ingestion of tobacco or caffeine? Then they need to stop that. And these can actually decrease the frequency and the severity of the patient's symptoms. Medications such as beta blockers can help suppress premature contractions. Other medications such as calcium channel blockers or anti-arrhythmic drugs also may be used if the patient has frequent PVCs that interferes with the heart function and causes severe symptoms. They may also perform a radiofrequency catheter ablation as well. It can be used for PVCs that don't respond to lifestyle changes or the medication prescribed. This is where they use a radiofrequent energy to destroy the area of the heart tissue that's causing the irregular contractions. So if you look at the different strips, the QRS wave is wide and abnormal in shape. So if you look at the top picture, you can see one wide QRS. In the bottom left, it is a coupled PVC where you see 2 in a row. And then if you look at the bottom right, you see triplets where you see 3 in a row. And then remember, if it is bigeminy, it's every other beat is a PVC, or every third beat would be trigeminy. So let's talk about ventricular tachycardia, or VTAC. It is a fast but regular rhythm. The heart beats too fast, where the ventricles cannot effectively pump oxygen-rich blood to the rest of the patient's body. So the impulse originates in the ventricles, usually with a rate of 150 to 250. It looks like a run of PVCs, which in reality it really is. There's no P waves because it does not originate in the SA node or the AV node. It is usually associated with coronary artery disease. If it lasts more than a few seconds, it can turn into ventricular fibrillation, which can cause the patient sudden death. The causes, sometimes it is not, or sometimes it's unknown. The etiology is unknown, and we really don't know what causes ventricular tachycardia, especially when it occurs in young patients. But in most cases, VTAC is caused by heart disease, such as a previous heart attack, congenital heart defect, hypertrophy of the heart, or dilated vessels within the heart with cardiomyopathy, or even after heart surgery. Some medication, including some of the antiarrhythmic medications which are used to treat other types of abnormal heart rhythm, these medications can cause ventricular tachycardia. But less common, but can be a cause, is electrolyte imbalance. Non-prescription decongestants Some of your herbal medicine or remedies, especially those with ephedra in it, like your diet pills. Other certain stimulants that can trigger episodes of VTAC is illegal drugs such as stimulants like cocaine. Also, cocaine. That's one of the ones that can cause ventricular tachycardia. Symptoms in VTAC: the heart beats so fast and the ventricles cannot pump the oxygen to the rest of the body, so they will have palpitations because that's how the heart is trying to compensate. Dizziness, lightheadedness because of decreased perfusion, shortness of breath, chest pain, all this for the same reason. There's decreased perfusion to the lungs. Angina, syncope episodes, weak pulse or no pulse at all, especially if the patient is about to die with this. Treatment depends on the underlying disease again and the patient tolerance to the rapid heart rate. So if the patient, can tolerate it, then they may not need treatment. If the patient is having symptoms and are in a sustained tachycardia, it is a medical emergency. The patient will need immediate treatment. The patient may also need antiarrhythmic medications such as amiodarone, which is IV. We give that IV, and the patient needs to will need CPR or shock from a defibrillator or AED, or electrical cardioversion to return the heart back to the normal rhythm. To prevent the arrhythmia from reoccurring, the patient may also need to continue to take the antiarrhythmic medications, or they may need an implanted device like a pacemaker, or an implanted cardioverter defibrillator or ICD. An ICD can detect any abnormal heart rhythm and it can restore the patient back to normal rhythm. On the strip with VTAC, on the EKG, there's a regular rate, but it's fast, 150 to 250 beats per minute. The P wave will be absent. The PR interval will not be measurable, and the QRS is wide, and it will be greater than 0.10 seconds, and it just has this bizarre appearance. So we talked about AFib. Let's talk about ventricular fibrillation or VFib. It is life-threatening. It is the most serious cardiac rhythm or dysrhythmia that a patient can have. The ventricles actually quiver and the heart cannot pump any blood, and it can cause the patient to go into cardiac arrest. The electrical impulses originate in numerous places within the ventricles, and it has an irregular appearance. There is no pattern. No atrial activity is seen on the EKG. Causes are the same as for VTAC, and it can happen as a result of untreated V tachycardia. Symptoms of cardiac arrest will be a sudden loss of responsiveness, no response to tapping on the shoulder. Hey, Annie, are you okay? You okay? No response. No normal breathing. The victim is not, or the patient is not breathing or has only gasping. This is a sudden cardiac arrest or SCA, which requires immediate CPR and defibrillation, alternating with vasoactive medications such as epinephrine, vasopressin, or even both. On EKG, the rate cannot be determined. The rate is usually greater than 220 beats per minute. The rhythm is irregular. The P waves in the PR interval and the QRS are not visible. So how do we reduce the risk of VFib? So a patient may be on antiarrhythmic medications, which may help control the disturbances within the rhythm. They may have an implantable cardioverter defibrillator, the ICDs, for high-risk patients. So ventricular asystole, also called a flat line. You never want to see this on the EKG. There is no electrical activity in the patient. The heart is not contracting and therefore not perfusing the patient's body. There is no heartbeat. You will not be able to palpate a pulse. The patient will not have any respirations. Of course, this is fatal. If this is going on, you better start CPR fast and call a code. Medical and nursing management is that we need to give quality CPR without interruption. Identify the underlying cause, such as if the patient is hypoxic or is in acidosis or has an electrolyte imbalance or hypovolemia, where there's a decrease in volume, coronary or pulmonary clot. Then we need to treat that as soon as possible, because the rhythm is not going to get any better if you don't treat the underlying cause. So while you are trying to figure it out, the underlying cause, that is, the patient will need to be intubated. An IV should be obtained. Hopefully, if a patient has a history of cardiac issues, then they should already have an IV. But if not, we need an IV. All of this while performing CPR. The patient will need, again, epinephrine and repeated doses in 3 to 5 minute intervals. A dose or two of vasopressin may also be given. Your book states that once this is done and no response, then call a code. But you would have already called a code as soon as you saw the flat line and you have assessed your patient to be unresponsive. You would have already called the code. So how do we assess a patient with arrhythmias? So assessment should include exploring all the possible causes of arrhythmias, all the contributing factors, and also the effect that the arrhythmia has on the patient's heart or their ability to supply the body or perfuse the body. We need to obtain a detailed health history, just like anything else. Does the patient have a history of symptoms of decreased cardiac output, such as syncope, chest pain, hypotension, dizziness, fatigue? Those are signs and symptoms that the patient has decreased cardiac output. We should be assessing to see if the patient has coexisting diseases that predisposes them to arrhythmia, such as heart disease, COPD, thyroid disease. Make sure we review any medication prescribed over the counter medication as well. We also should be reviewing past labs, which will give us information regarding the contributing factors. We should assess the patient for anxiety regarding the arrhythmia. Arrhythmias can be very scary and it can be dangerous, so the patient may have some concerns. Also, if they've had a family member die, for the same reason, then they may be afraid. So allow them to verbalize any feelings that they may have and answer any questions that they may have. On physical assessment, we should make sure we listen to heart sounds. We are assessing for any murmurs, extra heart sounds, S3, S4. Assess the patient lungs for wheezing and crackles. Assess apical pulse and all peripheral pulses for rate and rhythm. Assess for fluid retention, such as distended neck veins, edema, especially in the lower extremities. Also assess the skin for paleness and coolness, clamminess, which are all signs of poor perfusion. Assess the patient for the vital signs for blood pressure and heart rate. Count apical pulse rather than radial pulse, but you will assess all pulses for quality. It is more accurate. Remember, we discussed that before. And also assess the patient weight for fluid retention. A patient is usually diagnosed all due to what was I going to say with this? So all due to the heart not pumping adequately. The patient may have decreased cardiac output, cardiac arrest, heart failure. They may develop clots. They may have anxiety, and of course knowledge deficit. So these are the nursing diagnoses that we usually identify when a patient heart is not pumping adequately. So nursing management, what is the goal of treatment? Really, the goal of treatment is to eliminate or decrease the occurrence of the arrhythmias, and also to minimize the patient anxiety, and also to provide education to the patient. We need to obtain and monitor the patient vital signs, and also labs, especially their electrolytes. Also, the CBC to check for perfusion. Assess for signs and symptoms, contributing factors such as intake of caffeine, stress, abnormal stress, effectiveness of the patient medications, and adverse effects of the meds. We need to be able to obtain an EKG and also to be able to analyze basic EKG strips. All of the heart blocks and things like that, if you become a cardiac nurse, you will get better at identifying those type of arrhythmias. So the more you look at it, the more you see it, then the better you are at interpreting the strips. We need to help minimize the patient anxiety and maximize their control by allowing the patient to communicate and ask questions. We need to provide education on the arrhythmia that the patient is experiencing, the treatment to include medications. Should the patient take the med every day? How does the pacemaker work if the patient has a pacemaker? When to seek medical care and when to seek follow-up. Encourage the family to learn CPR and to also look for signs and symptoms of cardiac or heart failure. What are the expected outcomes? So what do we want the patient to do? We want the patient to be able to maintain adequate cardiac output by maintaining vital signs within normal limits, having a decreased episode of the arrhythmia. We want the client to be able to express a positive attitude, have confidence in their ability to take appropriate action in case they have an episode. We also want them to be knowledgeable about the dysrhythmia and their treatment plan. We want them to be able to verbalize understanding of the importance of taking medications every day. Patients should be able to describe their arrhythmia, in simple terms, and its effect on their body and how it makes them feel and what symptoms they will it display. They will be able to describe how to take their medications and what the side effects are. They will be able to verbalize the understanding of the importance of contributing factors such as staying away from caffeine in the diet. Understand the importance of follow-up. So those are your expected outcomes for a patient with arrhythmias. So cardioversion and defibrillation. So there's types of cardioversion and defibrillation. You have the electrical cardioversion, defibrillation, implantable cardioverter, defibrillator, and pacemaker. So I mentioned all four already, but we're going to actually talk about each of them. So cardioversion, again, is a procedure that can restore fast or irregular heartbeat to a normal rhythm. It is done in two ways, using an electrical procedure or using medication. For the electrical procedure, the heart is given low energy shocks to trigger a normal rhythm. The patient is temporarily put to sleep before the shocks are given. This type of cardioversion is done in the hospital as an outpatient procedure. Using medicines to correct the arrhythmia is also a form of cardioversion. This type of cardioversion usually is done in the hospital, but it also can be done at home or in the doctor's office. If the cardioversion is an elective procedure, we need to withhold digoxin, so as an anti-arrhythmia, 48 hours prior to the procedure. The patient should be NPO for 4 hours prior to the procedure. The patient will receive IV moderate sedation, analgesic, or the patient may need anesthesia. So if the arrhythmia lasts longer than 48 hours, they will give anticoagulants or administer afterwards because the patient is at risk for an embolus or clot. We need to monitor the patient for signs and symptoms such as sudden shortness of breath, neurological changes, headaches, visual changes, and motor sensory disruption. What should the patient expect after the procedure? Because the patient is going to want to know this. Patient may feel drowsy for several hours after the cardioversion because of the anesthesia that was given. The patient shouldn't drive or operate heavy machinery the day of the procedure. The patient need to arrange for someone to drive them home from the hospital after the procedure. The patient may have some redness or soreness on the chest where the electrodes were placed. Some patients are actually allergic to the electrodes as well, and they may have some burning of the skin. This may last for a few days after the procedure. The patient may also have slight bruising or soreness at the site where the IV was inserted. The patient may be on anticoagulants for several weeks after the procedure to prevent blood clots and also to prevent the repeat of the dysrhythmia. What are the risks of cardioversion? Because the patient will also want to know this. Although uncommon, cardioversion does, have some risk. The procedure can sometimes make the arrhythmia worse. Rarely, it can cause life-threatening arrhythmias that are treated with electrical shock or medication. Cardioversion can dislodge a blood clot in the heart. These clots can actually travel to other organs or tissues in the body and cause the patient to have a stroke if it travels to the brain. And then other problems can happen outside of that. That's why taking anticoagulants before and after cardioversion can reduce the risk. So defibrillation consists of delivering a therapeutic dose of electrical energy to the heart with a device called a defibrillator. Defibrillators can be external. It can be transvenous or implanted. Treatment of choice for VFib. If a patient has pulseless VTAC, but it's not used on patients with a pulse or who is conscious. Okay, so you don't want to use a defibrillator on someone who's conscious or has a pulse. So that's why you have to assess first. An ICD or implantable cardioverter defibrillator is a battery-powered device. I may be repeating this because we talked about it with the dysrhythmias, but I'm going to just go through each of the devices because you do need to know them. Generator that is placed under the skin that keeps track of the heart rate. Again, there are wires connected to the ICD to the heart. If the arrhythmia is detected, the device will deliver electric shock to restore the patient back to a normal heartbeat. ICDs have been very useful in preventing sudden death in patients with known sustained ventricular tachycardia or VFib. So you may have seen the pacemaker in your patient's chest when you're assessing the heart and lungs. It is implanted under the skin, so if you see a lump there, then you need to assess it. You need to also look at the chart, and you'll see that it was when it was placed and how long the patient has had it. So a pacemaker is a small device that is placed in the chest or the abdomen to help control an abnormal heart rhythm. It uses low energy electrical pulses to prompt the heart to beat at a normal rate. That's the purpose of it. It can be implanted temporarily to treat bradycardia after a heart attack or cardiac surgery or overdose of medication. It can also be implanted permanently to correct bradycardia or in some cases to help treat, a patient that's in heart failure. Although uncommon, patients can have surgery-related complications which may include infection where the pacemaker was implanted, just like with any other procedure, allergic reaction to the dye or anesthesia used during the procedure. They can have swelling, bruising, or bleeding at the generator site, especially if the patient is taking anticoagulants. They can develop a hemothorax where there's blood within the lung, the thorax. They can develop damage to blood vessels or nerves near the pacemaker. It can collapse the patient lung, puncture the heart muscle, which can lead to bleeding in the lining of the heart. And this is definitely a medical emergency. But really, life-threatening complications of a pacemaker when they're implanting it is very rare. But after the procedure, the patient usually is in the hospital for 1 day after the pacemaker is implanted. The pacemaker is programmed to fit the patient's particular pacing needs, of course, so it's really individualized. A return visit is often scheduled to make sure that the pacemaker settings are correct. After that, most pacemakers can be checked remotely using a wireless technology. The patient can use a cell phone or radio frequency signals to help track it, and the pacemaker transmit and receives information between the patient and the provider's office, and the data is just that it collects is the heart rate and rhythm, how the pacemaker is functioning, and also the remaining battery life. So this means fewer visits to the physician office, but the patient still needs to be seen for scheduled checkup to make sure their overall health is good. After the procedure, it's recommended that the patient avoid vigorous exercise or heavy lifting for about a month. The patient may have some aches and pain near the area where the pacemaker was implanted. And these pains can be relieved with over-the-counter medications such as acetaminophen or Tylenol or ibuprofen or Motrin or Advil, those type of pain relievers. So this is just a diagram of the different devices we just discussed. The cardioversion, you have your implantable cardioverter defibrillator, your pacemaker, and your automatic external defibrillator as well. So this is what you would see. If you look at the pacemaker, you can see that it's implanted under the skin. So when you're assessing your patient heart and lung sounds, just pay attention to that, because you shouldn't miss it, and you want to assess everything on your patient. And then when you check the chart, you can see that they had a pacemaker, placed 2 years ago or whatever. Sometimes they'll have it in and they haven't removed it yet because it's not working anymore. But you will see it. You can't miss it. So this concludes the lecture on cardiac arrhythmias. If you have any questions, please post it to this week's lecture week in the discussion board. Have a great day.